what I want to talk to you about a little bit today is Medicare services in the home care services, home health, also known as. Has anybody ever had to stay in the hospital overnight? What's one of the first things when you talk to a doctor, usually one of the first things that people want to know? When do I get to go home? There's some circumstances, of course, when it's best to stay put or to be somewhere else. But for the most part, most people want to go home and be in their own environment. And I think that has a lot of advantages. And there's actually been studies to prove that there's advantages to being in your own environment. So we're going to talk briefly about that today. And my second question to you is, has anybody tried to read a Medicare book?
It's insane.
I had someone the other day who kind of tossed it at me, and she said, you can have this if you don't have one because I can't understand a word it says. And this is a very well-educated woman. So let's first of all look at what home health is, and we're going to look at, this came from the Medicare handbook, their description of some benefits for home care. Medicare pays for you to get certain health care services in your home if you meet certain eligibility criteria and if the services are considered reasonable and necessary for the treatment of your illness or injury. What? I see certain in there a couple times. So that's kind of a very, and I know it was probably meant to be a very broad description of that. But after reading that, if I were just reading that, trying to figure out what my services were for home health, I probably wouldn't be able to determine a lot from that. Just a note, a reminder that this presentation and what I'm talking about today is with traditional Medicare benefits. As some of you are probably aware, we have a lot of different Medicare benefits out there now. I refer to them as HMOs, your private companies, Humana, Crestpoint, a lot of different things like that. So the information that I'm talking about today is referring to original Medicare. Unfortunately in those, and I'm not trying to cut corners, if we got into the details of those plans, we'd probably have to be here the rest of the afternoon. So if anyone has one of those plans and you have questions about what it covers, the best thing to do is call the number on the back of the card and they can give you the details about your plan. So let's talk about, I'll give a little bit, hopefully better definition of what home care is. Home health care is a wide range of health care services that can be given in your home for an illness or injury. Home health care is usually less expensive, more convenient, and just as effective as care you get in a hospital or skilled nursing facility. As I said earlier, there are times when those skilled nursing facilities or a hospital are the last resort. It's something that you have to do. So Candice may speak a little bit more towards some of the things that nursing can do and some of the things that are realistic for home health. The goal of home health is to treat an illness or an injury. Home health care helps you get better, regain your independence, and become as self-sufficient as possible. That's something that I think most of us really strive for, is to be in our home and it's to be as self-sufficient as possible. It's also a goal of home health to provide you with education so that you can better manage your disease or your illness in the home. We do a lot of diabetes teaching, congestive heart failure, COPD. There's a lot of different illnesses, and the role of the nurse and the therapist is to teach you how to manage that to hopefully prevent going back to the hospital, which we all have figured out that we really don't want to do. Unless you go to Franklin Woods. I've had a lot of people say Franklin Woods is pretty nice. Okay, so who's eligible? How do you get it? If you have traditional Medicare, you must be under the care of a doctor, and you must be getting services under a plan of care established and reviewed regularly by your doctor. You must need, and a doctor must certify, that you need one or more of the following. Skilled nurse, that's usually what people think of when they think of home health, is they're having a nurse to come out to their home. Physical therapy. Speech therapy. That's one that when I started this job many years ago, I learned a lot about what speech therapists can do, and it's amazing. Occupational therapy. So, in order to qualify for home health under traditional Medicare, you have to need one of those 4 what's called skills. Those are skillable disciplines. Another thing is the home health care agency caring for you must be approved by Medicare. I think that's something that we all would want, is to make sure that your home health agency has their credentials and has been approved, and somebody's monitoring what they do. This one's kind of one that we get questions about a lot. You must be homebound, and a doctor must certify that you're homebound. Again, now somebody might say, well, so-and-so has home health and they're able to go do this or that. Remember, we're speaking of traditional Medicare. They may have a different plan that's paying for their home health care. Some of the requirements may not be the same. So, what's homebound mean? It means leaving your home isn't recommended because of your condition. That's still a little broad. Your condition keeps you from leaving your home without help, such as using a wheelchair, a walker, help from another person, or needing special transportation. And again, that came from the Medicare website. That's straight from Medicare. You are allowed to attend church services. Of course, go to your doctor's appointments. If someone goes to adult daycare, they can still have home health. The visit has to occur in the home, is my understanding. It cannot be at the adult daycare agency. It has to occur in the home. So there are some circumstances where, of course, you are able to get out. And I'm not sure who made those rules, but that's, as of right now, where they stand. Has anybody had home health? Okay. Most people, like I said, their mind goes directly to nursing or a physical therapist. Some of the things that home health provides, some of the services are skilled nursing, CNAs for bathing and assistance with activities of daily living, medical supplies and infusion, physical therapy, occupational therapy, speech therapy, and last but certainly not least, social work. Because I am a social worker, I'm going to speak briefly about social work services. When I call a patient or a family member, I introduce myself and I say that I'm a social worker, I usually get one of 2 responses. There's either a very long pause and they say, "May I ask you why you're coming to see me?" Or they don't let me finish my sentence and they say, "Oh, thank God, I've been waiting on your call. We need blah, 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 blah." So those are the 2 most common responses when social work makes a phone call to set up a visit. To try to be brief, some of the things that social work does is, first of all, we perform a psychosocial assessment. And some people say, well, I don't want no assessment performed on me. I don't need that. Hopefully, if you have a good social worker, they will be able to perform a psychosocial assessment and you'll never know they've done it. What we look for, as most of you are probably very well aware, it's not just about the physical illness. That physical illness affects every area of your life. So we have our therapists, we have our nurses that have their special skills that hopefully can help heal the body, and then we have social work that comes in and hopefully helps take care of basic needs sometimes. If someone's hungry or cold, they're probably really not going to care if they take their insulin. Those basic needs have to be met. That's not all social work does. We do so much more. A lot of it is emotional support. It's connecting people to resources, which we'll talk about a few just in a second. So that's kind of an added layer to your home health services. Social work is not allowed to stand on their own. What that means is a nurse or a therapist has to be going into the home in order for someone to get social work services. The same goes for the CNAs to help with the bathing. Social work and CNAs cannot stand on their own. There has to be a need for a skill, and then we're an added service. All right, I'll stop talking about social work now. Gayla, I know you probably have gotten this question most of your career. Tracy, you probably get it too. A lot of people have misconceptions about what Medicare will pay for. So, I don't like looking at the negative, but this is something that's very important that we talk about because it's critical. Sometimes people have a false idea that Medicare is going to pay for somebody to come in their home and take care of them, and they have not made any other kind of plan. So for just a second, let's talk about what is not covered under Medicare. 24-hour-a-day care at home is not covered by Medicare. We get this a lot. Meals. People think when they come on home health services that they're going to get Meals on Wheels. Or they think that Meals on Wheels is something that Medicare pays for. That is not a covered item by traditional Medicare. Well, I need somebody just to come and shop for me and take me to the doctor and help me with my laundry. Now, I understand my Medicare will pay for that. Most of the time, I get to be the person that says, no, I'm sorry, it doesn't. The personal care, this is probably the biggest one I think we see. People just need help getting, and I don't mean just, but they need help getting a bath, getting in and out of the shower safely, dressing themselves, getting put wherever they want to be in their chair, and then they're kind of ready for their day. Unfortunately, Medicare will not pay just for that service to be in the home. Again, they have to meet one of those skills. There has to be something going on that they need a skill. Some durable medical equipment, and Candice, correct me if I'm wrong, traditional Medicare on some medical equipment pays 80%, and the patient is responsible for the 20%. Now, if they have a supplement, the supplement may come in and help with that 20%. And we would probably be standing here for 30 more minutes talking about which medical equipment's covered and which is not. I can tell you from the top of my head, something that I get routinely is a tub transfer bench. Medicare does not cover that. Handrails for the shower. Lift chairs. Medicare will pay for the mechanism, some of the mechanism that makes the chair lift, but they will not pay for the chair itself. So if you need one of those, please go to a company that deals with that. They can help file, at least get a little bit of reimbursement. Tub transfer benches, shower chairs.
Also, they have, instead of the chair, they have a unit that goes into on your seat that you sit down and it elevates you up itself.
Oh, okay. Is that something that Medicare would?
I don't know, I got it through the
Oh, okay. Oh, yes. I don't think Medicare pays.
Well, I mean, that would be in place of the lifting mechanism in the chair.
We don't disagree with you.
Yes.
Break the rules.
We definitely hear you. Yes. And that's one of the things that I was going to talk about next. Okay, where can I get these things that Medicare won't cover? First of all, sometimes it boils down to private duty sitters. If you know someone that's going to come in and help take care of your mom or whoever, it's private pay out of your pocket, private duty sitters. Non-medical home care agencies. We have, how many in the area now? About 33. Wow. And that's what they do. They come in and they help with the activities of daily living. They help with so many things that we're just not able to do. We can work together. We provide the medical piece, and they provide more of the activities of daily living, the transportation, and things like that. There's a program through the Area Agency on Aging called Options Program. Their services, I understand, are pretty limited, so if you're looking for somebody needs 20 hours a week help in the home, that's probably not going to happen through the Options Program. They are limited. Most people that get that program usually get someone a couple hours a week to come in and help with maybe sweeping, mopping, dusting, those things like that. But again, that's through the Area Agency on Aging that you can contact to see if someone qualifies for that program. Choices program, that is our state TennCare Medicaid program. And I will talk a little bit more detail if we have time about that. That's something that could go on, and I would probably give you misinformation because that changes very quickly. And as this gentleman just spoke about, veteran services. When I get a patient that is connected with the VA, I get excited because I think I might be able to get them some things that they need without, in a timely manner, I'll say it that way. So we love our veterans, and hopefully we can connect them with some services. Okay, here's the biggest question. Well, if Medicare doesn't pay for this, who's going to pay for it? I usually get to have that conversation with people too. They say, oh, we'll have the social worker come down and talk to you about that. Most of these services that we're talking about, you have to pay for privately. Private pay out of your pocket, out of someone's pocket, family, whoever it is. But I don't know how many people in here may have it. They're becoming more popular. You seeing more of them? Long-term care insurance policies? Good. Long-term care insurance policies help to pay for these kind of services in your home. It can add up really fast. If you look at a long-term care insurance policy, there's several different things out there. Look at it closely. Some of them have maximum benefits. And if you have to have around-the-clock someone in the home with you, those benefits can add up pretty quick. So just sit down, look at the plans, and compare those. Veterans Administration, Tracy and I were just talking about a program that is available for veterans or spouses of veterans, as long as they're not VA connected, right? It's called Veterans Care Coordination. Did I get that right? I was so excited to hear about this, and when they brought the brochures, I was just really excited. I think I've already given out all my brochures. But this helps pay for some services in the home to the veteran or a surviving spouse of a veteran. There are certain qualifications to meet, but I tell people you don't know till you call and see. So always try.
What's that called again?
The aid and attendant benefit through the association, right? Is that what you're referring to?
I may.
Is a separate independent company that helps get those benefits. But, yeah. I don't think the VA gives a lot of information about the aid and attendance benefit itself.
They don't.
They don't. It's them people we.
And it's hard to qualify for.
Yes.
It's for wartime veterans and their spouses. So if you serve during any period of wartime, you don't have to have been in a combat situation, but during that period, it's a very good benefit.
It is a very good benefit, but there is, of course, certain things that you have to meet in order to qualify for that. Medicaid Choices. This is, again, our state's TennCare program for long-term care that supports for elderly or physically disabled individuals that need help with things like bathing, getting around the house, preparing meals, or doing household chores. This program is not designed to take the place of the care you get from your family and friends. It's intended to work together as an added layer. Qualifying for this, I won't even begin to put, I can tell you that you must meet guidelines physically and you must meet guidelines financially. Again, if I went into detail and gave you all the information, I would probably give you misinformation. The qualifying physically, there's a list of things that they look for. It's things that you're able to do by yourself, you're not able to do by yourself. And here's a few more little guidelines, and I believe this is for a single person. This is talking about your income and your assets. So this program does look at your income and your assets. That can also, if you think you qualify, have somebody that may qualify, you can call the Area Agency on Aging. They can make a referral. If someone also already has TennCare, you can call their TennCare provider. Tell them that you want to make a referral for Choices program, and they can take it from there.
Are they attached in the home? Is the person owns the home, are they attached in the home?
I believe they do, yes. Yes. Kind of works like the nursing home Medicaid, that the home can be attached. Okay, that's kind of some home health services in a nutshell, and maybe some services are available in the community, especially things that I run into that's very common that I try to refer to. I think now we have Candice, who is going to talk to you a little bit more about some home care programs.
My name's Candice Greenlee. My background is in home health and hospice. Jackie's going to speak to you a little bit about hospice, and April's told you a little bit about home health. I'm going to expand a little bit more on the other services. My trade by, is a nurse. I am a nurse. When it comes down to it, after the budgets, after those type of things, the administratives, the teachings, the education, I am a nurse. So when you see me, you think nurse. Some of the things that I want to talk to you about is, what is home health care? I look around the room, there are some that could be at the age that they may have used home health services. There's some younger people around here that may not have had to yet. One of the things that we want to talk about with this is that home health can be considered for patients who are recovering from an illness. This could be an acute illness. You could have went to the hospital, had a really bad urinary tract infection or maybe a pneumonia, and you had to come home with some IV antibiotics. The undergoing treatment. We have a lot of patients that they're getting chemo, radiation, those type of things. They're immunocompromised. They are truly homebound. They cannot get out and go like normal people can. We have the disabled. We have chronically ill people, and we have terminally ill people. Hospice is not for everybody. I am the hospice manager, and I can tell you hospice is not for everybody. People have different belief systems, or maybe we're not to the point that we want hospice. And that's where home health kind of helps out. I'm also going to talk to you today about palliative care. And that is the bridge. That is the areas between home health and between hospice. One of the services that we provide is the nurse. This is me. I would come to your house. We can do things on diabetic education. We can talk about CHF, COPD management. These are disease processes. They're not going away. Short of a lung or a heart transplant, if you have congestive heart failure, you're going to continue to have congestive heart failure. Now, we can teach you to make some really good life decisions that can help manage these disease processes at home. Medication management, that's one of the largest things that we do. How many of you all have gotten a new prescription in this room? Who's gotten a new prescription at some point in your life? I see no hands, so we either have a bunch of people that aren't telling the truth or a bunch of very healthy individuals. So you get medications. What's the first thing your pharmacist asks you? Do you have any questions about that? Well, of course I do. I've never been on Lipitor before. I don't know what this is for. That's one of the things that we do with home health. If you meet the requirements and we come out, we can teach you how to manage your meds. We can set up a pill box. We can teach you how to do that. The better we can manage you at home means that you get to stay out of the hospital. Heard this gentleman talking about his story. We're going to talk a little bit about some disease processes with you. He was talking about, I had to go to the hospital, and I came back home, and I had to go back to the hospital. That's very frustrating. Nobody works really well on a yo-yo system, so we try not to do that with patients. Wound care, ostomy management. Some people have very unfortunate life events that ends them with an ostomy or a chronic wound. We have a lot of diabetics in this area that have diabetic ulcers, have stasis ulcers. Some of your parents may have become bedbound, may have gotten a pressure ulcer, those type of things. Catheter care. This is a really big one. The urologists in this area, they service a lot of the population, but there's some of the population that just can't get out to the urology office to have their catheter changed. Infusion therapy. This is where we start talking about those IVs. I don't know about you, but unless you've been in nursing school, that seems a little complicated for you to learn how to do your IV. We will come out and teach you how to do that. We will act as an adjunct to teach you how to do these things. If it's something that requires more skill, we will do them for you. And that's the whole point. We want to keep you out of the hospital. I don't know a single well person that goes to the hospital other than as a visitor. If you go to the hospital and you are well, you won't stay there. They don't keep well people in the hospital. So our goal is to help you manage your things at home. You're used to being at home. And then we have the CNAs. They can come out. They can help do baths. They act as an adjunct to you all. Physical therapy. If you've ever had a knee replacement, if your parents ever had a knee replacement, if you had a fall, you talked earlier with Rhonda Broderick about fall prevention. If you've had a fall and you've broken a hip, you can go to a skilled nursing facility and you can do extensive rehab. You can come home, you can have rehab in your home. That's an option too. The post-hospital rehabilitation, we have a lot of people that go in with pneumonia and they get very, very sick. They're very weak. They don't have the stamina that they had prior to going to the hospital. So they go home with physical therapy. Physical therapy helps them get back to their functional level. Now your functional level may be a wheelchair. You may have went to the hospital and you're now bedbound. We're going to get you back to that wheelchair. That's the goal. Or we're going to get you a little past that and we're going to get you up walking. That's what we want to do. Balance and training strengthening. You all see me, I'm kind of a young whippersnapper here. But I can tell you I've been to physical therapy myself. I played a lot of sports growing up and I had to go to physical therapy for my knee. That's a service that I utilize. You all have that access too in the community. You have physical therapy clinics or they can come to the house. The home safety evaluations, this is one of the biggest ones that I hear from caregivers. Mom's went, she's had a stroke, it's a very traumatic event. We're not sure about mom's recovery level of where she's going to get to with that stroke. We bring her home. I'm younger. My house is designed for my children. My house isn't designed for my elderly mother who has a stroke. So they come out and they walk you through your house. They start telling you things. Okay, we need some handrails here. Need to maybe look at moving these rugs. You know, okay, well, this toilet seat's a little bit high for mom. She's not going to be able to get down to use the bathroom. Those basic needs, those things that she needs in the home to help her feel stable, to help her be safe. They also do a lot with fall prevention and DME. You know, if you've ever had to use any type of medical equipment, you realize the instructions that come in that box, it's not working real well for you. They actually come out, they teach you how to do your cane. I'm a nurse by trade. I don't do physical therapy. I don't know how to do as much. You know, they can actually tell you the exact height based off of measuring between your knee and your feet that your cane needs to be. They can tell you if you need a straight cane or if you need a quad cane. That's what they're trained to do. The occupational therapy. These are the people that get you to eating, drinking, being able to feed yourself, teaching you how to button your shirts, how to do your clothing. I didn't realize, but they've got some really neat contraptions that can actually help you lace your shoes. They can actually have little buttoners that help you button your shirt if you've lost the dexterity in your fingers. And those are some of the things that they're going to help you with. Speech therapy. You heard April talk about this. These are some of my favorite people because they deal with food, and I love to eat. You know, I'm from the South. I love to eat, and this is what they do. They teach you how to eat again. You know, Mom's had that stroke. She has what we call aspiration. She aspirates her food whenever she eats. They will teach you some ways that you can get around that. There's a 10-chuck method. There's also different types of foods that you would want to feed them, and that's what they help you do. We also do speech. You know, we have several speech therapists that will go out to pediatrics homes. You know, children that have learning deficits and things like that, they can actually help them, walk them through their speech patterns, and that's what the speech therapists get to do. Why choose home care services? I'm not going to go through each of these individually because we've already kind of talked about them. You heal best when you are at home. You heal best, you do better when you're around people, your loved ones, your family. Now, there may be acute illnesses that you cannot manage at home. You may need to go to the hospital and get some help. But the ultimate goal is that we want to go home. I have never discharged a patient from the hospital that flat out told me, I don't want to go home. Now, they may have said, I'm not ready to go home yet. I need to go to rehab. But I have never had anybody tell me, I don't want to go home. Don't send me home. Please don't send me back home. You know, they want to go home. That's what you all want to do. I'm much happier in my home. I get to wear my fuzzy socks, my pajamas, those kind of things, and that's what you get to do. That's what they're going to help you do with home health. They keep your family together. There is nothing more tiring than having an 80-year-old mother and her 60-year-old daughter both at a hospital. You know, that 60-year-old, she is not the spring chicken she used to be, and it's not good on her to be in and out of the hospital. She's going to get very tired, and she's not going to be able to care for her mom, and that's what we want her to be able to do. So we've got to get both of them back home in a structured environment where we can help them get better. We want you all to be as independent as possible. I mean, I realize that if you were in an accident and you're wheelchair bound, you may stay wheelchair bound, but we can certainly improve your quality of life, and that's the whole point. We want to get you as functional as possible. You know, I always say, well, I'm like a used car salesman selling home health. I really think it's that great. I've done it. You know, I've never been the beneficiary of it because I haven't reached that stage of my life yet. But I would imagine that if I had to, for any reason, I would use it. I've seen it work really well for a lot of families. You know, it really lets them have advantages that they wouldn't have had otherwise. You know, who here likes to go to their doctor? Raise your hand. I see no hand raised. You know, home health they act as an adjunct between you and your physician. No, physicians don't make home visits anymore. There's a few, but very rarely do they make home visits. And it is not convenient for you to get in your car or call your daughter and have her come get you, take you to the doctor's office. You spend 3 hours in the waiting room, then you finally get back, and then you're tired, and then you get home, and then you're hungry, or then you got to go back out and get your prescriptions. That's exhausting. It's exhausting for anybody, and we don't want that to happen. And there are some things in the community that can help you with that. You know, you've heard the speech about home health. You understand where home health sits. Home health is for people that are seeking treatment, that we are trying to fix. That's what I call it. We're fixing them. Fixing something about them, whether we're fixing their medicines, we're fixing them physically, we're fixing them emotionally, we're fixing their IVs, we're fixing things. And then you have the other end that Jackie's going to tell you about hospice. Hospice isn't that we don't fix things, we just fix different things. We fix you. We prepare you and your family. Palliative is kind of the bridge between that. Palliative is for those people that maybe you've been given a terminal diagnosis and you're not quite ready to throw in the towel. Or maybe it's your belief structure and you can't throw in the towel. Maybe you have a child that says, no, Mama, I want you to keep going. I really think you need this chemo. Let's do the chemo. You know, I've seen families have this conversation. They weren't ready for hospice. You know, for you to go to hospice, you got to be ready. Everybody needs to be ready. So palliative kind of falls in the middle of that. And what we do with the palliative program, you still have to fall under the home health guidelines, meaning you still have to be homebound, you still have to have a skill, you still have to have a reason for us to be there. Jackie's going to tell you about hospice, and she's going to explain that you don't have to do any of those things. Hospice, as depressing as it might be, they get to be the fun guys. They can actually pack your things and send you on a cruise. You don't have to meet any of those guidelines. So that's what we're going to talk about palliative. It's an area of healthcare that focuses on specific symptom relief. That is what we want to do. We want to teach you how to manage yourself at home. You know, home health, figure you need to be 3 to 6 months at most. You know, our average stay for home health is anywhere from 2 weeks to 2 months. Palliative, you have a much, much longer range. You have an acute illness, then you have palliative, and then you might get to hospice. I'm going to walk you through a disease process at the end of this that kind of explains that. It's a multidisciplinary approach. You have physicians, you have nurses, you can have therapists, you also have chaplains, and you have those wonderful social workers who are actually one of my best friends. I see April every day. I go down and visit her every day for our patients. Provides a team of professionals. These doctors, they meet on you. You know, don't think that, okay, well, the left hand doesn't know what the right hand's doing. If your palliative system is working the way that it's supposed to, the left hand knows exactly what the right hand's doing, and they're both in cahoots to get you to where you need to be. It began in the 1980s, something that Jackie may or may not mention. Hospice, it really didn't get going in the United States until about the 80s, and that's when Medicare decided that we should probably pay for it. So everybody else jumped on the bandwagon. So hospice is a relatively new philosophy when it comes to insurances paying for it. Palliative's sort of the same way. 80% of the U.S. hospitals have some type of palliative program because they understand we're not going to fix you. If you have COPD and you are in stage 3, we can't fix you. You know, like I said, short of a heart transplant, lung transplant, we can't fix you. But we can teach you how to manage it, and we can make your life a lot more comfortable and make you a lot more happy. You know, we want you to be able to go to your family functions. We want you to be able to get out, do things that you enjoy. Maybe you like football. Maybe you don't. Maybe you like to go to the park. Maybe you don't. But you should at least have the opportunity to be able to do those things. Studies that show that lung cancer patients receiving palliative care, they have less depression and they actually live longer. It is a common misconception. Most patients that go under hospice live longer. Most patients in a palliative program live longer. And it's because we manage your symptoms and we keep you out of the hospital. And that's what it's there for. This just talks about it provides relief from shortness of breath. We have common symptoms that we refer to all the time. They're pain, anxiety, nausea, and then you have shortness of breath. These are 4 symptoms that are most commonly utilized in the hospital. If you're short of breath, you're going to the ER. I would. I don't like not being able to breathe. It makes me anxious. If I'm hurting, I'm going to go to the ER. I hurt. I don't like to hurt. I'm at least calling someone. If I'm nauseous, I can't eat, I can't drink, and it starts that cascade. So if you have those big symptoms that we talk about, those are the things we want to help you manage. We talk about affirming life. You know, there's a difference between quality and quantity. The quantity is the thing that we really talk about, and palliative is how to get that and to reap the benefits of the others. You'll see a chart in a minute. It offers support to your family. You know, that's one of the biggest things. It's kind of like home health on steroids because you get a little extra. You have the team approach, try to increase the quality of life. And if you catch it early enough in your disease process is when you get the most benefits. You know, if you're already to the point in your disease process where you're tired, you're not doing anything, you've given up, we need to catch you before then because we can keep you from doing those things. We need to get you early. Now, this is some of the differences between palliative and hospice. Palliative care, you don't have any restrictions. Hospice, they're not going to let you do a lot of curative chemo, things like that. You don't have it under palliative because it falls under the home health benefit, which means you can go seek active treatment. You can still get your chemo, you can still have people come see you. You can have your chronic disease with no progression. You know, with hospice, you have to show decline. You have to get there. Palliative, you kind of don't. You may seek treatment for your diagnoses, and you still have that multidisciplinary approach. With hospice, you have to have a certificate of terminal illness. Physician has had to tell you that you have 6 months or less to live. Progression of disease is required. You have to show decline. For Jackie to be able to keep her patients, she has to show that you're declining. Well, we talked about that span. Remember, we talked about the timeline of, okay, I've been given my diagnosis, and then I may have this 3 to 5 years, or a year, or however long my progression is. And then we get to the end. You know, this is what we're talking about. The curative treatment, we don't do a lot of curative treatment for hospice. That's not what it's for. It's not to fix what's wrong with us, it's to fix us. It's to fix us and to prepare us to pass. You also have the multidisciplinary approach. This is an extra layer that is on top of your home health. I can tell you the way that we utilize our palliative, they are seen by hospice nurses and home health nurses. Home health nurses are geared to fix. Hospice nurses are geared to symptom manage. It's what we do. So we've combined them and you get both. And the reason that we do that is because the hope in the transition is the way this works is you'll be with home health. You'll figure things out. You may go into a palliative care at some point along your disease process. And eventually, if it's right for you, you'll go to a hospice. And that is the timeline because we don't want anybody to have to go through these things by themselves. The worst thing that you can do is to tell a lady that she has breast cancer. You're going to put her through lots of surgery, and then she's going to have lots of radiation and chemo, and then she's going to get to a point where the doctor said, you know, we didn't get it. We're just not there yet. She's going to have a lot of anger. She's going to have a lot of feelings. And then eventually she's going to get to the point of acceptance. You should never have to be alone in that process. That's not fair. It's not fair to do to anybody. It's not fair to ask a daughter to sit with her mom at that appointment. Not by herself anyway. You know, nobody's trained to do that. It's not what they're trained to do. We are. My nurses are trained to do that. So that's some of the things we're talking about. Now I do want to mention to you a disease process. I told you at the beginning of this one little wonderful tangent that I've had about the timeline that we were going to talk about. We're going to use COPD. This is a very big diagnosis in this area. Happens to a lot of people, and there's multiple stages, so it's a really good one to use. You can do the same thing with congestive heart failure. You go to the doctor, kind of short of breath, not feeling real good. You went to your doctor, and he says, okay, well, let's send you to a pulmonologist. I'm not real sure why you're not breathing as well, but let's go to a pulmonologist. Pulmonologist tells you that you have COPD. You have been given, for whatever reason, your lungs are failing, and you start to have symptoms of COPD. Okay, well, we're going to go home with home health. Well, we're going to have home health come in, and we're going to teach you about your disease process. Home health nurse steps in. They start talking to you about your medications. They start talking to you about the symptoms that you're going to have. They start talking to you about the progression that you're going to go. Your average COPD person, the progression is between 3 and 5 years. At some point in the 3 to 5 years, you will transition in one part to another. Some people are different. Some people live 10, some people live 2. But that is the timeline. So home health, very start, very end. We work with you, we get you managed. Then we have that middle part, and that's where palliative comes in. We have got to teach you to manage your symptoms. If you have COPD, I promise you, you will go back to the hospital quicker than anything if you're short of breath and you have anxiety. If I'm short of breath, I'm going to freak out. If I freak out, I'm going to the hospital. I'm calling 911 and I'm going. We want to keep you out of the hospital. There's some medications that we use in hospice that help you do that. You know, I can give you a long-acting narcotic that will help depress your drive to breathe, which will make you less short of breath. I can give you oxygen. I can teach you how to manage other medications. And that's what we want to start doing. We want to start managing these medications early because it increases your quality of life. You know, you may not have to take medications. We can teach you, one of the things that April does is she teaches you symptom management in your own body. She teaches you how to manage you. She can walk you through de-stressing techniques that will actually let you slow down, rewind your brain a little bit. That way you don't get as stressed or you don't get as anxious. And that's what the palliative's for. It is to be the bridge. It's not anything special or new or any, type of new candy they're trying to sell. That's what it's for. It is before you get to the point where you need hospice. And there will come a time that you will eventually get to that point. But I just wanted you all to know this is what palliative's for. We want to combine the best of both worlds. I can't tell you that everything's great and wonderful. There are areas where the progression goes so long that it can be uncomfortable for everyone. But I want you all to know that you have options. You have home health, you have palliative, you have hospice. These are all things that we can help you through in your own home. That way you don't have to keep utilizing the hospital. That way you don't have to keep going back like this poor gentleman. I'm sure he does not like to go back. You know, I'm sure it's uncomfortable for him when he has to do those kind of things. I'm sure for anybody it's uncomfortable. You know, we want to keep you at home. And you've got a couple of, at least now, you see some of the things. Oh yeah, I remember that lady that was there. She said something about diabetic teaching. Maybe I can talk to my doctor and they can send a nurse out. And if I meet their criteria, they can come out and see me and walk me through this. So I'm going to let Jackie talk to you all about hospice. If you have any questions, we're going to be available afterwards to answer some of those.
I'm going to pass out or let you all pass around copies of my PowerPoint. On time, you'll have it. Okay. Can y'all hear me? I'm usually pretty loud. I don't necessarily need the microphone, but I will keep it on. I am Jackie Everett. I'm a certified hospice and palliative care administrator, and I am the manager of hospice services for the Wellmont Health System. One of the other things they wanted me to talk to you about today was not just hospice, but as well as about advanced directives. I found it very interesting that one of our first speakers today talked about how when you pack up your child to go to kindergarten and you pack his little book bag and you get everything ready because he's going to school, and then he goes to middle school and high school, and you plan that. You know, when you're a parent, you plan that your child's going to have everything they need for that first day of school. And then when they're in high school, you want to make sure that they've got everything they need, that they get to experience everything, that they're not just going to school, they're into sports, they're into extra activities. So you're making all those plans for them. And you're planning that hopes that one day they're going to also go on to college and they're going to have a great, bright career. You planned all those things. But then we get to the point where we've finished a college, you know, we're making our career, and all of a sudden we stop thinking about what's next. We don't plan something that we're all assured to do, because I don't know of any other way to get out of this world but pass from it. But we don't plan for it. Advanced directives is all about that journey. Advanced directives is your map. It's how you decide, where am I going? What do I want to do? So, what is it? It's a written statement of your wishes about health care and your treatments. What are your choices? I was lucky. Mike Dietrich with the Tennessee Hospice Association brought me the most recent. This was just released within this last month. This is the most current Tennessee Advanced Directives form. Okay? So this is a roadmap. This is a tool to help you to be able to tell others, your family, your loved ones, your physician, your healthcare providers, what you want. Why do you need it? You might be seriously ill. You might be injured. You might be in a car wreck.
Can we go online to get that? Or
I have plenty of copies, but yes, I do believe you can go online and get them. I have these, and there's some more out there on my table. Okay? If you're injured, who's going to speak for you? I learned something today. Isn't it great to learn something every day? There's a very nice lady. I think she's out of them now because everybody heard about them. Tennessee has started a new program called the Yellow Dot. Everybody know about it?
Yep.
Little sticker that you stick in the corner of your car windshield. And it tells first responders, if you're in a car wreck, that you have your medical information. Right there, she's holding up one. You have your medical information in your glove compartment. Isn't that wonderful? You do have to put your little picture in there, and you have to keep everything up to date. But I would really recommend, if you have an advanced directives, put it in there. Put it in there. Because this is a great tool, but it's useless if nobody knows where it is. It is useless. So there's two parts of an advanced directives. The living will, that's a legal document. Doesn't have to be notarized. You can have it notarized if you'd like,
but normally just 2 witnesses that are non-family members, or you can have it notarized. But it's basically your statement about your choice. What do you want? How far do you want health care to go? Okay? Then the medical power of attorney is the other part of that, and that's the part where you say, hey, if I can't talk for myself, I want my daughter, I want my son, I want my cousin, I want my best friend to be that person that speaks for me. So your medical power of attorney only becomes effective when you cannot speak for yourself. You're not giving someone else the right to speak for you if you can speak up and say, no, I don't want that. But if you can't speak, then your power of attorney can. It's also known as a healthcare agent, a proxy, a surrogate, or a durable power of attorney for healthcare. Some of the medical terms, and you will see them on this form. Life-sustaining treatment. That's the kind of stuff about if you were in an accident, if you were terminally ill and you know that you're not going to recover from it, would you really want to be on a machine? Would you want them to continue to artificially keep you alive? That's life-sustaining treatment. Artificial nutrition and hydration, tube feeding. But you know, medical advances have come a long way, but no matter what we try and what we learn, we're still not going to quite make all of those miracles that you see on the TV hospital shows. It's amazing what they can do. You know, bag of IV fluids and everybody's better. Doesn't quite work that way. Okay? IV fluids can actually make things a whole lot worse in some situations. COPD, congestive heart failure. Your body's already having trouble dealing with your fluids, so let's pump another bag of fluids in there. That's really going to help. So depending upon your disease, you may not want artificial nutrition. You may not want IV fluids. You may not want tube feedings. You can say that on this form. CPR. You know, you see that in the medical shows too. They're always able to bring people back. The problem is if you already have a known illness, a known chronic illness, CPR is not going to fix that. If they do bring you back after they've electric shocked you and pounded on your chest and done that CPR, you're still going to have COPD and congestive heart failure. You're still going to be just as debilitated as you were before that event, and maybe even worse. So it's your decision, how much of that do you want, okay? And then do not resuscitate orders are basically a physician's order. Usually it is because you have had a conversation with your physician and you have said, if I get to point A, point B, point X in my life, do I or do I not want to be resuscitated? When my time comes, God calls me home, am I going to stay or am I going to go? And do I want you all to intervene to make sure I get to stay? That's what a DNR is. The advantages to having advanced directives: you're in charge. This says you are. This makes sure that everybody knows this is what my wishes are. You can change it anytime. You change your mind about something, another form, 2 more witnesses, or a notary, it's fine. Update it anytime you want to change something. You don't need an attorney. I don't know if there's any attorneys in the room, but they really do like to charge a nice fee to fix out some fancy forms. But this one will do it all. And you don't need to pay their nice fee. Okay? The other things are these start conversations. You know, sometimes it's kind of hard to talk about end-of-life issues. It's kind of hard to talk about what's coming next. But these documents are easy ways to have conversations about not only what you want, but what other people that you love want. You know, there's times when you're sitting there with your mom. Recently, home health. My mother-in-law had to have IV antibiotics at home. One of those times, sitting there after we've gone to the hospital, we've had the PICC line put in, we're planning the IV antibiotics. She's 86 years old. And she looks at me and says, you know, Not really sure how much longer they're going to be able to keep fixing this old body. Mom, have you done a power of attorney? Have you put anything in writing? It's a good way to start a conversation. I really want to respect what you want, but to do that, I've got to know. Okay? It is one of the most wonderful, loving gifts you can ever give to those you love. There is nothing worse than standing in the waiting room of intensive care or the emergency room being told, I'm really sorry. I don't know if we're going to be able to make this better. Did you ever talk to your mother about what she wanted? Did you ever have a conversation? And if you can say, she's got a living will. She's got an advanced directives. We had that conversation. And I know where it's at. It's in my little yellow bag and it's out there in the glove box. So having that conversation is extremely important. Yes?
One other thing too is even though the person may be capable of it, with drugs, with debilitation, all those sort of things, they may come and go with their opinions, they may vacillate, and put you in all kinds of anxiety, or you put someone else in all kinds of
Right.
anxiety because of your flakiness at that particular time.
Right.
When you're still able, but not able to do it.
Yeah, especially those Alzheimer's, dementia, those type of illnesses. You know, you may have one moment of clear thought that you may have the chance to do it. But if you can do it early on in their illness, that's very, very helpful.
I've worked at the hospital forever, and to see patients standing, or families standing there, you know, this is not just for elderly folks, this is for people my age. I have a living will, I have a power of attorney because I didn't want my son to have to make difficult decisions. My brother knows what to do, when to do it, how to do it, why to do it.
Right.
And we've talked about scenarios and been very honest about it. And so if he makes a decision, he makes my decision.
Right. So the disadvantage of this is you may not have it with you. So you need to, everybody needs to know where it's at. It may not be specific enough, although having seen this new document, it's pretty good. It covers a lot of stuff. And it can be overridden by your physician, any physician. So it's important that you're letting your health care providers know what you want. If you've had a conversation with your physician, if you complete this document, take a copy to your doctor, your dentist. Wonder if Joan Rivers had one when she was in there getting that endoscopy. Any health care provider should have a copy. Okay? I like this statement. It's about how you live. How you can remember something. This is a statement that's been around in NHPCO for many years. Live is, L is for learn about your options, I is for initiate your documents, V is for verbalize what you want, and E is for educate others. It's about how you live. Nothing can be more important than to have this discussion with those you love and to make sure that the person you've chosen to be your advocate, to be your surrogate, knows what you want. Okay, I'm going to skip through a few things here. I think I've already talked to you about these things, and I really want to get to hospice. Okay, we've had a little bit of information about hospice. Okay, so and they've mentioned hospice a little bit. Some of the biggest things about hospice that I'd want you to know is that it does recognize dying as the normal process of living. Hospice is not about dying. It is about adding life to the days you have. It promotes quality of life. You don't have to be homebound. We've already heard that. You don't have to have a skill. What qualifies you for hospice is that you have a life-limiting illness that two physicians, your attending physician and the medical director of the hospice program you choose, agree that if this disease process runs its normal course, that your life expectancy is 6 months or less. Okay. Look at the PowerPoint. We do provide a lot of the same services that home health does. It is a very interdisciplinary approach to care. It's a holistic approach. She's right. I usually tell people, you don't have to be homebound. We're not going to put you on a cruise ship and pay for it, but we'll put you on the cruise ship. We're not going to put gas in your car, but we'll help you get to where you want to go. It's all about what's most important to you at a time when you're dealing with a life-limiting illness. So, thank you.